Welcome to our abdominal vascular pathology lecture, part 5 of 5, assessing transplants. We're going to cover a brief overview and a preliminary look at liver, kidney, and pancreas transplants. So who needs a transplant? The people who are typically put on the transplant list are on there because one or more of their organs have stopped working. And if they don't get the transplant, there is a good chance they will die. Now, the whole transplant process and how you get on the list and how you are considered for it is extremely complex and beyond the scope of where we need to be for transplants and sonography. However, it's important to remember to be compassionate with these patients. A lot of times they are waiting for a transplant for years, and many people do die while they are waiting for that match to be found. Now, to get onto the transplant list itself, there are going to be certain criteria that the patients are required to meet, oftentimes including, a very advanced stage of disease, the likelihood of them dying without the transplant, and then what the likelihood of the survival post-transplant. And we might be part of the pre-transplant process. We'll be evaluating kidneys for changes. We'll be evaluating the liver for changes, the pancreas for changes. And when the structural abnormalities become severe enough and the laboratory values become severe enough, they will get placed on that transplant list. Unfortunately, there are a lot of people that are not able to get transplants due to many complicating factors. Some of those are going to be having widespread cancer. Do they have a cancer that's not curable? Is it in multiple organs? That is not going to be a good candidate for a transplant. Are there any current infections? Do they have HIV or AIDS or other systemic diseases? Or is there a history of non-compliance or alcohol or drug abuse? I think back to an episode of Scrubs that I was watching. There was a patient that finally had a liver match. They got in, they were talking to him. He's like, I just had a little sip of champagne at my daughter's wedding. And he was there for a liver transplant. Now, I don't know if this is as strict as it gets, but they do have to follow rules. They want to give the organ to the person that's going to have the best chance of survival, the one that's going to be compliant with all the rules and medications and follow-ups and everything that goes into receiving the gift of an organ. So there are certain qualities that a person cannot have to be eligible to get a transplant. Now, the United Network for Organ Sharing, or UNOS, is responsible for maintaining the list that I've been talking about. And once a patient is put on the list, they get ranked, and they're kind of in this order. But what typically happens is once an organ is available, they go through the list and they look at who's a tissue match for it, who's a blood type match for it, is the recipient, what's their immune status, how long have they been on a list, and what's the distance between donor and recipient. Surprisingly, the distance between the donor and recipient actually has a really big role in it. If there's a heart down in Florida available for you, they are not going to send it over to Seattle. They're going to find someone in a much closer geographical setting, despite maybe being in a more severe case in Seattle. So unfortunately, there are a lot of things that just need to line up for a patient to receive their transplant. So what role does ultrasound play in the transplant process? Well, as I had mentioned earlier, ultrasound is actually going to be very helpful in diagnosing patients with diseases that lead to transplants. Postoperatively, however, we can also be used to evaluate the connections that the surgeon made for the new organ. These connections are called anastomosis, and these are going to be connections of blood vessels and of ducts. And we can use ultrasound to evaluate flow through them, the patency, and help to predict the likelihood of the organ transplant being successful. The other thing that ultrasound is really helpful in is looking for any abnormal fluid collections, hematomas, urinomas, biliomas. We can also look for abscess in the area. We can evaluate the parenchyma of the new organ to also kind of evaluate how well that organ is faring. Another way that ultrasound is very helpful is to guide a biopsy. Now, biopsies are actually the best way to evaluate for transplant failure. They take a little sample of the new organ, see if it's getting enough blood, does it have any necrotic pieces in it. They can evaluate it for quite a few things to determine if the body is accepting versus rejecting the transplanted organ. We're going to begin with liver transplants. Now, there are tons of diseases that can lead to liver transplant. These lists are not exhaustive. However, I do want you to know that cirrhosis due to hepatitis C is the most common reason for a liver transplant. You'll also see on the list many diseases that affect the entire parenchyma of the liver, like hemochromatosis. If you recall, that one is too much iron within the liver. Wilson's disease is too much copper within the liver. We also have biliary issues that can arise that can lead to transplants as well. Now, there are a couple different types of liver transplants that can occur. You can have a cadaver transplant. So once a person dies, if they are a match and an organ donor, they can remove the liver, preserve it for 12 to 16 hours, and get it into the recipient. One of the other common ways that people get liver transplants is through a living donor. And through a living donor, a friend or family member who is a match can direct their donation to a patient. And this is going to usually include the right lobe of the liver being donated to the recipient. Postoperatively, we will be responsible for assessing the allograft. Allograft is another word for transplant. So when we are looking at a liver transplant, it's going to be important for us to read the surgical notes to identify what type of connections or anastomoses that the surgeon made when connecting the vascular and ductal components of the liver. Once we figure that out, we are going to go in and use color and Doppler spectral tracing to evaluate all the connections and the blood flow directions. The most common vascular complication that comes along with liver transplants is hepatic artery thrombosis. So we want to make sure that the hepatic artery is completely patent with normal velocities and direction of flow. We also want to evaluate the liver parenchyma. When it becomes more heterogeneous, that is a suggestion of failure. And we'll evaluate the perihepatic area for any abnormal fluid collections, including belomas or abscesses. This image here is a nice reminder of where some of those anastomoses can occur. Now, when a surgeon removes the liver for transplant, they actually are not going to remove just the liver and cut all the tubes and vessels right next to the liver. They're going to leave a little bit of a leading edge. And those leading edges are the ones that are going to be then sewn or anastomosed to the recipient's native blood vessels. So we can see that the hepatic artery needs to be reconnected. We can see that the splenic vein, the inferior vena cava above the hepatic veins, and the bile ducts all need to be reconnected. Moving on then to renal transplants. Again, we have lots of reasons why patients receive renal transplants. At the top of the list, we have hypertension and renal artery stenosis, and diabetes as probably being some of the more common causes for renal transplants. There's also glomerulonephritis and interstitial nephritis. There are times that patients have systemic infections that can greatly affect how the kidneys work, and that can lead to failure of the kidneys, which leads to a renal transplant. Renal transplant recipients have 3 options available to them. The cadaver and living donor are similar to the liver transplants, where the cadaver just needs to be a match of somebody who has died. Living donation can come from a friend or family member that directs their donation to the recipient and have a better survival rate. There's another type of renal transplant that can occur, and that's called an autotransplantation. That is when the patient's own kidney is moved to the transplant location. Now, that might kind of seem a little weird, but there are times where either the ureter isn't working the way it should be, or maybe it's injured, severed in a car accident or something like that. Maybe the renal artery has been so severely stenosed that they can't do much more for it, like stenting or anything like that. Maybe they have cancer in part of the kidney or some other conditions that they can actually take the healthy part of the kidney and move it into the iliac fossa, and in that instance, they can reconnect the ureter, or they can reconnect blood flow to the kidney from the iliacs. So we can actually remove the kidney, put it into the iliac fossa, and kind of redirect the urine path and the blood path to maybe alleviate some symptoms of severe disease. When it comes time to assess the allograft of the kidney, we want to make sure that we are looking down in the lower quadrants in the iliac fossa. So anytime there is a transplant performed, it is usually placed into the iliac fossa, either the right or the left side. Down here then, the renal artery is connected to the external iliac artery, and the renal vein is connected to the external iliac vein. This also provides a shorter distance for your ureter to be connected to the bladder. Our responsibility with ultrasound then is to again check all the anastomosis, making sure that we are looking at flow direction and for any stenosis within the connections. Renal artery stenosis is the most common vascular complication following the transplant, and that's usually going to happen right where the renal artery is connected to the external iliac artery. We also want to evaluate RIs throughout the kidney, just like we do with our renal artery stenosis Doppler, and we do not want our RIs to exceed 0.8. Again, we should also evaluate the parenchyma of the kidney. Heterogeneous again suggests failure, and we'll look for any perinephric fluid collections, including urinomas, hematomas, lymphoceles, or abscesses. During the renal allograft, they do not remove the native kidneys, so it's important too that we also evaluate the renal kidneys with ultrasound. And so here's an example of a renal transplant. We can see that the renal kidneys have been left in the renal fossas, and the transplanted kidney is placed down in the iliac fossa, either on the left or right side. The iliac artery is connected to the renal artery, and the iliac vein is connected to the renal vein, and the ureter is implanted into the bladder. Lastly, then we'll take a look at pancreas transplants. Pancreas transplants usually are going to occur because of diabetes, most likely type 1. Again, there are a couple options for pancreatic transplants. You cannot give up part of your pancreas, so most pancreatic transplants are going to be cadaver. When they remove the pancreas from the cadaver, they are going to take a lot of the midline pieces that we see. So they're going to remove not only the pancreas, but part of the duodenum, the portal vein, the superior mesenteric artery, and the splenic artery. The second type of pancreas transplants that are available is something called a pancreatic islet cell transplant. This is when a patient's own islet cells are removed from their pancreas, and then they're auto-transplanted into the hepatic sinusoids. This gives the body the opportunity to still benefit from the endocrine function of the islet cells, such as the glucagon and the insulin and the somatostatin and all those endocrine functions that we learned about with the pancreas. There have not been a ton of these types of transplants done. However, the limited data that there is has shown some improved insulin production and regulation in these patients. When it is time to assess the pancreas allograft, again, we need to know what type of surgery was performed. There are two methods that are typically used for transplanting the pancreas. The first one is exocrine bladder drainage, and this is where the pancreas is placed in the iliac fossa, usually down on the right side. The portal vein is going to be connected to the external iliac vein, and the superior mesenteric artery and the splenic artery get connected to the external iliac artery. The important part of this one, though, is that the duodenum then gets connected to the bladder for drainage of exocrine substances. So remember that the pancreas is also responsible for producing pancreatic enzymes, and those are typically released through the duct of Wirsing into the duodenum. When we transplant the new pancreas in, we need to figure out a way to have those exocrine juices drained safely from the body. We don't want them just kind of draining out into the parenchyma. We know that that can lead to some serious complications. So exocrine bladder drainage, the main point is that the duodenum connects to the bladder to drain the exocrine substances. Now the second method is called the exocrine enteric drainage, and this is the most common type of transplant that will be performed. With this one, the pancreas is placed more into the right upper quadrant, so a little bit higher than the bladder drainage method, and a graft is used to connect the SMA and the splenic artery to the common iliac artery into the external iliac artery. So it kind of creates this Y between all the vessels. The portal vein then can be connected either to the common iliac vein or to the external iliac vein, and this time the duodenum is going to be connected to the jejunum for drainage of the exocrine substances. So the basic part of exocrine enteric is that the duodenum is connected to more intestines, specifically the jejunum, to drain the exocrine juices. So here's an example of exocrine bladder drainage. There is also in this picture a kidney that has been transplanted. It is very common to see renal transplants in conjunction with pancreas transplants, as diabetes can lead to failure of both of these organs. So in the exocrine bladder drainage, again, we have the main vessels of the pancreas connected to the external iliac artery and vein, and then we have the portion of the duodenum that accepts the exocrine substances is connected to the bladder for removal. In this example then, we have the exocrine enteric drainage, where the portion of the duodenum is connected to the jejunum to drain those exocrine substances. Note that the pancreas is typically more in a vertical position with both of these, a little bit different than its native horizontal position in the body. So thank you for watching the Abdominal Vascular Pathology lecture series. If you have not had an opportunity to watch parts 1 through 4, I do suggest that you check on those. Otherwise, this concludes the Abdominal Vascular Pathology lecture.